So I'm Heather Morgan. My Twitter handle's there, happy to be contacted on Twitter. And also I've put my university profile and my own sort of profile there, because part of what I'm going to be talking about tonight is related to my research at the University of Aberdeen, where I'm a lecturer in applied health sciences, and where most of my work concerns digital health, particularly personal digital health tracking. And that's sort of within health services, health and social care services, as well as in health research. But I'm also someone who, I suppose, labels myself, considers myself a fitness tracker, a quantified self, and more recently, perhaps a biohacker, depending on how you want to define that. And I've put a link there to my blog where I reflect on use of different technologies for sort of personal reasons and reflections on health and potential, I guess, for using various apps and devices for personal digital health tracking, as well as it's sort of in conjunction with health and healthcare services, which is what I'm going to talk about tonight, which is this kind of idea of these two worlds, and perhaps them colliding at some point. So both in terms of more formal digital health tracking by health services or researchers, and the idea that people might be tracking themselves or using devices, and how this might sort of be integrated or implemented within formal healthcare to, I suppose, maximise the benefits for all. So let's have it. So this is it, the image, the stock image, sorry, the PowerPoint stock image of two worlds colliding. It's not exactly quite how I see it. It's maybe perhaps more of an overlap. So I'm not sure if that analogy works. But the way I see it at the moment, I suppose, is there's a lot of potential and a lot of things going on outside of health and social care services, but this kind of very slow idea of digital health and personal computing fitting into health and social care, or people's management of their own health. We know that we've got lots of issues around, people living longer, and particularly around sort of lifestyle behaviours that could perhaps benefit from tracking, people sort of being more aware and conscious of their health, and how this might sort of, I suppose, improve health and healthcare, but also some of the perhaps pitfalls, I suppose, around over tracking, perhaps effects on mental health. And I'll talk about some projects that focused on those aspects a bit later as well. So thinking about digital health, when I first started thinking about this kind of area, and I should say my background is actually, my PhD was in sort of policing research and the use of technologies in policing and prison services. And so I came into health research in 2012 after I finished that work, with the kind of focus on surveillance and the use of digital technologies in sort of public service delivery. And I became really interested in, okay, this is how it works in the sort of criminal justice areas. What is the kind of position potential in healthcare? And coming in at that point, a lot of the focus was on sort of telemedicine and telehealth, and that was the language. But then that quickly moved more into the digital health kind of definition or terminology, sorry, and not so much tracking, but things like the NHS apps library you might be aware of, and the initial scandal around that, where apps were developed and were uploaded into this apps library, and people were using them, not necessarily because their doctors were recommending them, but they might have come across them in the NHS apps library while searching for certain things. Obviously the NHS brand, people then think this is safe, this is evidence-based, this is okay to use, but there were a lot of problems with people uploading data, and the data security was not good, and the whole thing was pulled. It was a research project that looked at this, and as a result of that research, it was a university in London, I can't remember which one now, but the PhD student who identified this, that led to the apps library being pulled, and then a new system being developed where to get your app made available within the app's library. You had to meet certain criteria. So there are these kind of NHS branded apps that are there, but that's just one kind of digital health on offer. And obviously with the pandemic, we've had a kind of shift towards this e-consultation as well. So that was previously available to some people across the UK in terms of where there were, I suppose, big waiting lists. Accessing a GP, for example, was particularly difficult. And in some cities, London, and I think Blackpool might have been another one, there was this Babylon Health that was I suppose a commercial enterprise that the NHS kind of integrated into its systems there and trialed. But obviously with the pandemic and people being at home and not accessing services so much, we've seen the rollout of e-consultations becoming sort of more commonplace through GP surgeries. And I in fact made use of eConsult last year, must have been April last year, for the first time with my GP. So these are the kinds of digital health sort of provision that we see as the kind of things that we're perhaps used to and familiar with, or more familiar with. But I think, you know, the things that I want to talk about tonight are perhaps pushing beyond these boundaries and exploring more possibilities, I suppose, for digital tools within health and social care. So when I first kind of came to this work a few years ago now, I started to think about, well, what do we mean by digital health? Because as I mentioned before, there was this kind of terminology of telehealth and telemedicine that was kind of more emphasis on remote and rural care and getting services to people so they didn't have to travel, rather than this kind of everyday idea of maybe apps or e-consultations for, you know, even if you just live around the corner from the surgery. So there's been that shift, but then thinking about those technologies, they're still not really making use of perhaps wearable devices, commercial apps, commercial alternatives, and so on. And so that was what I was really interested in, sort of trying to distinguish between the different types of technology. What do we mean by technology? And I was also really interested in this idea of self-tracking as well. And at the time had been doing some work on chronic health condition management. So did this review here where it was quite boring, to be perfectly honest. It was 3 months of funded work that was really looking in depth in the literature. It wasn't the kind of exciting stuff that I'm used to doing, which is talking to people and getting out there and observing people in the real world using stuff and talking about their uses of stuff, which I'll come on to. So this was really desk-based work and looking in depth into the literature. You can see from the table there that kind of there was a lot of literature, but equally at the time that, you know, that it was looking back to some innovations, but they were still not quite where we're at today, obviously, just the way time and technology sort of develops. But you can see here that I was interested in the kinds of different aspects, and particularly things like experimental use versus actually medical necessity or convention. You know, something part of regular clinical kit was distinguished from new stuff that was being given to patients, perhaps trialed with patients, or in fact patients perhaps creating themselves and using in relation to their healthcare, and then things being written about. So actually some of these studies involved quite large numbers of people, and some of them involved one person. There was it's a really cool picture. I remember it. I should have put it on the slide actually. It was almost like a briefcase. It looked like something from the 80s really. This enormous briefcase with all of these different peripherals and wearables and things that sort of popped out of it. And it was used with one patient to test whether they could do remote tracking of a range of different conditions and so on. So this kind of gave me a bit more of a, I suppose, a sense of what was out there, what was already being done, what was perhaps more novel compared to more traditional, and you know, what the kinds of issues were. And you can see here things like, you know, clinicians perhaps already being familiar with potential particular types of technology versus actually you know, a new system or a new training required. Other things as well, you know, like the commercial alternatives and involving users' own equipment as well. So a lot of the stuff that, you know, we have seen before that we might deem as a technology might have been provided by the health service, whereas we're seeing much more of a kind of creep to actually people using their own devices, including for the NHS apps. And obviously eConsult, you're using your own technology to interface with these. But still, this was quite sort of limited, I suppose, and obviously it was literature based, so it was looking backwards to things that had been done previously rather than new things. So that was a good project in some senses, in getting that overall grounding. But then I really moved into doing a bit more work around things that were actually being used in practice today. These are, I'm going to go through a few research projects here that focus on different types of digital health technologies that track individuals, or individuals might use to track themselves. So this project was a really interesting one, and here you can see me on the left with a different hair colour and wearing an ambulance jacket. So I did some research in the backs of ambulances across Scotland. It was observational research, which is really the kind of research that I tend to do rather than the desk-based stuff, but obviously not this year. But so I rode out in ambulances looking at ambulance clinicians' uses of electronic records and, I suppose, patients' expectations and interactions in the backs of ambulances. So this was a cross UK project, and in fact, you may know that the Scottish Ambulance Service has been using electronic records now for over 10 years, whereas other parts of the UK were not. Some were still using paper records. In Wales, one of the ambulance services, or the Welsh Ambulance Service, sorry, was using sort of digital pens where they overwrite onto paper, and then it kind of scans overnight into a PDF sort of version. But we were looking really in this project at the different types of electronic records, patient expectations when they're taking the back of an ambulance. You know, what information do they expect ambulance clinicians to be able to have about their health and their health records at hand? How are decisions made? Are they made by the ambulance clinician, or are they made using the kind of app and decision tree format that is in some of these sort of tablet equipment that are used in the backs of ambulances? And what do people think of them? So some of the sort of technical issues. And one of the things that really stood out to me in this project was that in Scotland, you know, it is quite advanced in terms of having this electronic record that they create about a patient, but actually access to information about that patient isn't so easily at hand or readily at hand, and patients do expect that might be there. But the really striking thing was whenever we stopped at a hospital to take a patient in, the ambulance clinician would go back out to the ambulance, complete the record, and then print a version of it, sort of a shiny receipt paper, and walk it back into the hospital and hand it over. And I remember seeing one of these handovers, and the nurse, the receiving nurse, was stood at a sort of computing station, and they were taking the vitals from the patient, and she just folded up the piece of paper and put it under the keyboard. And so there was no sort of interaction, there was no upload of that information into the patient record. So that patient's sort of digital health tracking ended almost all that effort to fill in that record, and it was printed out and put under the keyboard, and goodness knows whether it was then put into a paper record or what. But quite disappointing when you think the effort that has been gone to. And I know that they're working on this in terms of being able to make that information available to GPs, for example, that they could then transfer overnight. And they were looking, but because of the way the NHS is not just the NHS, and we have different health services and different computing systems behind all of that and infrastructure, that's very difficult to be able to just automatically upload information that's being collected about a person during that kind of moment of them being in the back of an ambulance. And some of that information that might be of use in the care that they're receiving now, but also in the future, and that's potentially lost. So that was a really interesting project, just thinking about sort of digital health records and how they work or don't work, or do for a particular purpose, but perhaps not to their full potential. So beyond that, the next sort of project I want to talk about is a project that a clinical trial that we've just recently completed that's looked into childhood asthma. And this one was a really interesting study in that we were recruiting children with asthma, and we were using an algorithm instead of clinician opinion or clinicians' knowledge or understanding of the patient to actually treat the patient. So the idea is here that exhaled nitric oxide is a biomarker that could be used to indicate when a child might be coming towards an asthma attack, and that by exhaling nitric oxide into the machine that you see here at the top would give a score, and then the clinician would then input that score into the algorithm that was created for this project, and it would give a recommendation of treatment, whether to up, down, or stay the same. And then the child would be given that medication, and then they would be monitored using a smart inhaler for that. And they were followed up at various points over the coming year. And my role in that, I'm a qualitative researcher and social scientist. So my work was really leading on the design of the interview study. So we interviewed clinicians and we interviewed patients and their parents as well about this experience of being treated by algorithm and smart monitored as well with the asthma inhalers. And what we found was actually, I suppose, more interesting in terms of the clinicians, because their adherence to using the algorithm was quite interesting, and their views about, you know, having the safety net of their own judgment and being able to actually reject the decision of the algorithm, this kind of uncomfortableness about using that was really interesting. So that study we will be publishing soon. We've just submitted the report to the NHR. But it's really interesting insights into the use of technology, comfortableness with using these devices for two different reasons, obviously one in clinic and one at home. Some of the technical issues as well around upload of data, patients sort of thinking that the smart devices weren't working, if they were showing up non-compliance with asthma treatment, and then they were getting different readings and so on, was quite interesting. So that's one study there where we think, well, technology's really added something, but it's also given us some insights around uncomfortableness around technology as well. And that's also, it's a clinical trial, so it's time limited, so that's finished now. The other one that I've been involved with over the last year and a bit has been this ASICA trial, which is around skin cancer. So people who've had skin cancer, and the idea is that, again, in a clinical trial, they would be, patients would be recruited and have a skin map, a personalized skin map made for them, and then they would be given a tablet. So this idea of giving the devices, and again, like the asthma devices, is provided in the context of the trial, and patients here were being asked to repeat skin assessments themselves at home rather than coming into the clinic. And the idea is that sort of proactive monitoring, self-monitoring, and the use of this technology to do that would perhaps improve outcomes, because patients might be more likely to notice things earlier, and they could also get sort of feedback on it as well. And we found that there were, again, some technical issues and some sorts of complaints about things that could be improved. But in general, we saw that patients were quite keen to use the technology, found it a positive experience, and also that skin checking was improved among patients who took part in the trial. Things gonna I'm just going to take a quick sip of water. So this is the newest one, eye track, and this has just recently started. And this study, again, a clinical trial, is looking at home monitoring of glaucoma. And you can see here that it's an app on an iPad and also a handheld monitor. So combining two types of technology here. And this one's presenting some issues of its own in terms of whether something is defined as a medical device by the MHRA. And because the app has been created, and just thinking back to that kind of NHS apps thing, and the data leakage, and there's, you know, some issues, I guess, around where things have been created and what the parameters of them are, and if they're defined as medical devices, which I think this project's only just started and we haven't really fully got to grips with all of this, but we've had some discussions and we might have to change the app that's going to be used on that basis. So just trying to get that in place at the moment. But thinking about this again, this idea of home monitoring and being able to use devices in the home is quite interesting and exciting. And again, we'll be doing interviews with people who participate in this trial to get a sense of their experiences and acceptability and their perceptions of how this works and so on. So another project as well, this is one you can see here, it's got the track changes on. It's another project that we're working on just now that's about to start interviews with people who've used this calculator. So this is about outcome prediction in subfertility. This is a sort of calculator that's been created based on Scottish data around fertility, and will make a sort of prediction, can make a prediction based on individuals' information that they input. So it's not tracking as such, but it gives people who are looking to start a family a sense of where their chances are, and it updates along the way as well. So if there's unexplained subfertility, this might be useful for people, and it's freely available on the university's website. But the work that we're going to look to do is actually explore people who have used its experiences, but focusing not just on the technical but also the emotional aspects as well. And you know, you can see here that things like disappointment and hope. So if you're using a calculator that's based on big data and statistical modeling to calculate your own chance of something related to your own health, an important issue, how does that feel, and is that appropriate? So again, we're just about to start this project, but just to give you an idea of some of the stuff that we're looking at. And the other thing that I've sort of recently become aware of in terms of sort of app-based tracking is this new COVID-19 vaccine trial, which is a plant-based vaccine. And the reason I have come across it is because I volunteered to take part. So they've already sent me the app information to download ahead of my appointment next week. So I've downloaded that, and it'll be interesting to see, just having read the patient information leaflet and the kinds of information that they'll want me to record. And one of the questions on the phone on the screening was, will you have a problem recording things in an app? And I said, probably I'll have the opposite problem. They'll get all of my data and information because I record a lot on apps, which I'll come on to later. So that's just another one there. But it's interesting seeing these different technologies starting to become part of research, but obviously not sort of standard practice. They're still being explored. They're still kind of in their infancy, and we're still trying to work out what's acceptable, what people's experiences are, and so on. So I suppose here is this idea of, obviously health is really important, and we don't want to just you know, get everyone wearing wearables and putting information into apps and not knowing what we're actually doing with these things, and being certain of things like security and what impact that might be having on people's health and so on. So I think the caution is is wise in many ways, and obviously we can build in ways to research this into projects. But it does feel that somehow progress is quite slow, or certainly I feel like that, but perhaps that's because I'm an early adopter and enthusiast, which is where my other world is, or my other hat in this talk. So just with that in mind, I suppose I'm always quite enthusiastic about potential, and with students, I supervise a lot of student projects. And so here is a recent one that I've just finished with an undergraduate student, an intercalating doctor who is interested in heart health, and particularly among women, because women participate less in cardiac rehab. So she was really interested in technology and how it could be used to I suppose, increase engagement and participation, or perhaps in the programme that is currently run according to the NICE guidelines, or whether something, an alternative. So she actually looked at all the barriers to participation and the sort of parameters of the current model according to the NICE guidelines of how cardiac rehab is delivered. And she also did a review of all the devices that you see here, using the Which magazine online, because of the information is sort of standardized, I guess, across that, and their user testing and so on. So she did this really neat, she did a lot more work as well, not just produce this table. She did a literature review, but she did this mapping to how could these devices address some of the barriers and the requirements of the cardiac rehab. And there's a lot of potential there. You can see among one device in particular, but this was a really interesting piece of work. So this idea that, well, could we actually be maximizing our use of these technologies? And that was sort of one of her findings. One of the other projects I've supervised recently was looking at multiple sclerosis management and whether technology could be used. So looking at, according to NICE guidelines, when technologies could be used, and what sort of evidence levels we would need to be able to do that, and how that mapped to current multiple sclerosis sort of diagnosis and treatment, and the sort of disease modifying techniques that might benefit from technology. So that's another one of my students who's just completed that piece of work with a UK focus as well. So it's this idea of like looking forward, what things could be used and put in place that are already there, that we might look to actually mapping. So we're not kind of going gung-ho with just throwing technology at things, but looking at if you systematically map the types of technologies that are available, the types of data that might be used to the clinical care pathways, what does that look like then? So that's been really interesting, particularly looking at different types of clinical areas as well. And then you have me, and this was, these are a couple of headlines which don't report what I actually said. But just thinking, I'm always thinking to the future, and not just clinical pathways in terms of people who already have a diagnosis or a condition, but just in general, sort of lifestyle, because not everyone's on a clinical care pathway, not everyone's engaging with health and social care services unless they need to or at that point. But, in general, are there other ways that we could use technologies to promote healthy lifestyles, to support people? And these unfortunate headlines were published a few years ago now, based on some work that I had published in the Conversation magazine online. I can send the links to people so you can read the real headlines if you want. But I think the point's kind of still made about this idea of the potential of technologies, I suppose. And actually, with that in mind, myself and another student, Kelly Buchan there, we decided to partner up with a company who had created a wearable device and app platform for weight loss. So we did this study with women who had suggested that they had a desire to lose weight. And they came in, and it was just a small, we only invited 20 women. In fact, it was really interesting because we only had 20 devices. It was kind of, I suppose it was sort of beta testing of the device and the app. But I think within a day, or it was, yeah, perhaps a day, we had 120 volunteers for this research and only 20 places. So it showed us that there was an interest in using a device, using an app for weight loss. And we did a mixed method study. So we looked at the actual physical outcomes as well as talking to the participants. And we did see some moderate weight loss. It was only a short-term study. But we saw that people really liked not just wearing the device and using the app for themselves, but actually the sort of social aspect as well, because they were able to share their sort of results. They're able to chat to each other and so on. So this was an interesting study, but weight loss moderate, but the kind of engagement with it and the excitement and enthusiasm around it was really interesting. So that kind of, and that happened after those headlines. So that kind of showed that, yeah, there might be something here, but this is obviously still not among general population. It is among, in this case, women who wanted to lose weight. Which, when we come onto the kind of ethics part, we can think about, you know, whether it's appropriate to use devices and monitor people, or whether certain people want to be monitored and so on. There are kinds of questions around, you know, if this was to become part of provision, NHS provision, how would that work? So here, just thinking about, I'm just thinking about, you know, will the bridge come down, and will we be able to sort of cross over and see that these worlds perhaps not colliding, but actually joining up, so that you can kind of meander, or a bit more fluidity between the kinds of digital health tracking practices that are possible, what's perhaps used within healthcare, what's perhaps used outside of healthcare, whether it's for specific conditions or specific populations, or just among the general population, and how might all of that work. So another study that we finished last year, or no, the year before, was actually then looking at, okay, not just people who have a condition or have expressed an interest in a particular aspect of their health, but just people in general. And we were really interested in what doctors and healthcare practitioners had as experiences of patients coming in and just sharing what they're doing sort of in the wild. And so this was an interview study that was conducted among healthcare providers, not all based in the UK. But what we found was that the doctors who came forward to take part in the study tended to be early adopters themselves. And as such, you know, there is a bias there in that, you know, it seems that those more comfortable with technologies themselves might be more comfortable talking about technologies with their patients. But what they did say was that actually there were sort of far and few between, and there weren't very many incidences where people were coming in to their GP or nurse prescriber with any actual data themselves, which kind of surprised me. But then I suppose it would, because I'm probably one of the annoying people who will bring in everything on my mobile phone. But I have to remember that that isn't everyone. So yeah, it seemed that at the moment it's kind of, there are potential gains to be had and conversations to be had between clinicians and people using devices, but at the moment it's not happening enough, and there's not a kind of script for that, and there's certainly not training more broadly among other healthcare professionals who might not be early adopters themselves or use technologies themselves. So that was an interesting one. One where we've done a couple of different pieces of work here is looking at fertility tracking. So I mean, this isn't just among women who want to conceive, but just in general, we've done a couple of studies here looking at fertility tracking apps. And the second study here, we actually partnered up with Clearblue, the pregnancy testing company, to do this piece of work. And it was really interesting in terms of the different aspects that people were sort of commenting on. And again, these were both surveys and then follow-up interviews. One just focused on people's everyday uses of fertility tracking apps, and the second one was really focusing on predicting conception and whether women would be interested in a specific type of tool. So this is focusing on current use, and this is focusing on potentially future use. So the calculator that I mentioned earlier, the Opus, the idea is that it could be then converted not just to a sort of website calculator, but that it might be possible to build it into a smartphone app that women could then use. And then we started to then reflect on what we found in this study, which was there are certain types of apps that are more popular that people use. And, you know, if we created a research one, would we wouldn't be able to benefit from perhaps the amount of data that some of the companies already have on women's fertility tracking. But also we wouldn't have the kind of market necessarily. And if we found that in the study that women sort of were quite wedded to their particular tool of choice, that once they found that their kind of app, they really stuck to it and liked the way it worked, and had collected data over a number of years, and really wanted to sort of stay with that. So this idea of creating a new tool, we would then have to think about, okay, how would we then integrate or work with these commercial companies who already have got all this data and the customer base, as it were. So some interesting things to think about there, developing that going forward. And so that Opus study, when we actually find out what people think of that calculator, will also bear that in mind as we move forward. Other things that we've looked at has been use of smartwatches as well. So this is a recent one that was just completed last month, and again, it was interesting because this project was delayed in getting started due to getting ethics approval, or the time that it takes to do that. And in the end, I think the survey was only open for less than 5 days, or if it was 5 days, and we got 201 responses, which is pretty good. And it's quite interesting that, you know, people were very keen to take part in this, and this involved follow-up interviews as well. And it was focused on women's uses of wearable devices, and looking at both physical and mental health and perceptions of their effects. So we did look at things like, you know, what were the most popular devices, but also how people had changed their habits based on the device that they were using. But what we found really interesting was that we asked if participants in the research would want to receive the results of the research. And normally there's not a huge uptake of that normally, but a lot of our participants in this, I can't remember the exact percentage now, but it was more than half wanted to actually get the results, and it seemed that people were quite keen to know how they compared with other people like them. And some of the quotes from that research were just really interesting in terms of how people were feeling, like the messaging in particular of their device, and the kind of relationship with it, taking it off or not taking it off, feeling really bad, feeling negative, changing habits, feeling sort of bullied, I suppose, in terms of activity levels, and monitoring calorie intake and so on. And the sort of psychological impact of that has been quite interesting. And it's sort of, yeah, increasing activity, and we looked at things like injuries and so on, and intensity. So it was a short study, obviously. It was an undergraduate project, but again, some interesting insights. And we did have some people who participated who don't have a wearable device, and that was part of our inclusion as well. We were interested to hear from women who don't use a wearable device, why that is, why they're not interested in doing that, or perhaps had previously and had stopped. We've also done some work on smartwatches among runners. So this was another study here looking at physical and psychological effects as well, and things like when people won't go for a run unless they have their watch charged. People like me who won't do the thing unless you've got the watch on and they're collecting the data. And just looking at things like enjoyment of the sport, what kind of data that people are using. Are they pushing themselves, setting different goals? Is it about heart rate? Is it about distance? What kinds of things are people really interested in? And how do they behave? So again, another interesting study, and you can see there it's very small, but again, looking at which devices were people using, and what kinds of I suppose effects did they perceive that the technology had, and what kind of, and you can see here the kind of intrinsic value of running, and how using technology or technologizing that activity changed it, or changed experiences of it. And then the final sort of research project, I suppose, that I'll talk about in this part is the wrist-worn ECG stuff. So another student project, I worked with a student, Ryan, and he looked at the ECG stuff. So after Apple Watch brought out the wrist-worn ECG, looking at, I wrote an article for the Conversation magazine again, based on, I think they asked me that time to write something, but they kind of, based on the concerns, I suppose, that this is not a medical device, this is not clinically approved, and what kinds of things we might need to think about if people are doing a one lead, effectively a one lead ECG on their wrist, compared with what you might get in a clinic, with several different leads, so up to 13 leads if I remember correctly. And I suppose the panic around people who might do these things and then get false positives and then be burdening health systems, or might be really stressed because they might be sent away by their doctor, but their watch is saying one thing but the doctor's saying another. And this kind of, if you put the tools in the patient's hands or population's hands, then is that kind of dangerous, I suppose. The main kind of things that we found, I suppose that some of, or he found, it was a literature review project, was looking for kinds of issues, so incorrect readings being the main one, but also some of the improvements that could possibly be made. But the kind of key issues is where perhaps the ECG might be most useful, which population groups it might be most useful, is perhaps not the target market of the wearable device producer, developer, manufacturer. So the kind of mismatch there. And this is just because I'm a sucker for buying new stuff. As soon as I could get the ECG Apple Watch, I had one, and this is, but I quickly got very bored of doing them. You can see just oddly there, it looks like I've done that almost once a month. But to be honest, I did it a few times on the first day that I got it, and then don't really do it at all. It's not really, I don't find it very interesting. You can see like how different that one looks compared to this one, just by chance. It tells me that there's nothing wrong with my heart, but I don't know. But the thing that I find really funny in this is that you can press create PDF and email it to your doctor, which obviously can't really do in the UK. So obviously different healthcare systems as well. It's if you've got private healthcare providers who make that functionality possible, I guess there's perhaps scope in the future. But yeah, something that I think is interesting to think about. And that's pulse oximetry that my watch now does. So I do have I had a thing that I put on my finger previously, and now it does it through my wrist. But I don't know if that's correct. I don't at all. But it's interesting, but again, I don't really do it that often because it's interesting, but my phone will probably beep if something's going to be wrong, or that I need to think about. So, and I think having that perhaps in the background is quite useful, but perhaps having that over a period of time as well is what's even more useful. So, you know, tracking healthy people over the life course might be something where we actually see the added value of this, rather than that sort of panic of, or that excitement about getting the technology, or the panic of getting a reading that's not correct, or doctors' frustrations with it. But it might be helpful over time to build up a picture of an individual, to be able to pinpoint when things perhaps go wrong. And that's something that I think about. It's not just perhaps about treatment of conditions, but actually, if we can track things over time, is that where the value might be realised? And so on that, I sort of said I've got the second hat on, and that this, my experiences, and I suppose because I'm so interested in technologies, I have a personal interest in doing it, not just for myself, but I suppose to develop some insights. And part of the reason why I write the blog is it's called autoethnographic writing. A lot of the work that I do is ethnography, which is going out, and it involves a lot of observation of people in their sort of natural environments, and using technologies in practice and so on, and then writing about that. And I suppose I'm kind of inflicting upon myself what I do in terms of research. So it's a kind of self-research project. But just thinking about all the stuff that I track, in terms of sort of activity, I set goals every day that I have to close all these rings. I had a really bad day last Tuesday, but you can see here I had a really bad month in February. I wasn't able to run a lot because we had a lot of snow, and wasn't able to walk a lot because there was a lot of knee-deep snow. And it was interesting to just observe. I knew I was having a bad month exercise-wise. You can see I've conveniently not screenshotted that one. I'll show you, it's not good. But you can see that my fitness level really dipped there. And I'm trying to get that back up again there. But I track all my activities that I do, and set goals as well, and compete in different things sort of digitally. And I find this really motivating in terms of I suppose keeping myself going, but also just thinking about, I suppose, what health means to me, perhaps, but having all this data and being able to look at it, but also thinking about the frustrations and challenges I have as someone who's not a computing scientist, not a mathematician, not a statistician, a data scientist. You know, I'm kind of limited in what I can do with it, and that I find that quite frustrating. And maybe I'm just collecting data like ridiculously, but I not only use the sort of automated stuff using the wearables, but I also, and I've been a quantified self since I was a teenager. So I used to use this book to write down everything that I'd eaten over periods of time. And I use the NutriCheck app now to input everything that I eat. And you can see I'm monitoring different things, so fiber and water, and you can change this to look at what you're perhaps interested in tracking. And maybe it's ridiculous doing this in terms of the amount of data generated or what the practice serves to do, but I certainly find it useful in terms of, I suppose, being motivated to do exercise and to eat healthily, and to, I suppose, feel healthy. It doesn't, for me, feel like a burden, but I suppose I also have to consider that I'm obsessed, and it is a bit of an addiction, so perhaps it's not such positive behavior in some ways. I've also done menstrual cycle tracking since I was a teenager, so paper-based to moving it to app-based as well. So this idea of, you know, it's not necessarily about the technology. Maybe it is some types of people are interested in sort of quantifying themselves, maybe, and I have to consider that as well. Maybe it's not for everyone if we're thinking towards integrating digital tech into health and social care. You know, some people would be horrified about having to do this. The other thing here is the running. So you can see February really was a bad month. And as a result of February, I set myself a 200k challenge in March, because I was so fed up of not having run a lot. Although if I look back to August and September last year, they weren't too good either, but something really just sort of made me think, I'll click the 200k challenge on Strava and I'll do it. And I should have updated because I did go for a 5k before the hill, so that should say 106.91, and it is because it was 5.00. And actually this is another thing, so when I'm out running, I'll quite often look on Strava and then think, okay, what do I need to do to get my number to an even number, or to get it to the 25 mark, or that, and it is, I mean, it's probably quite ridiculous, but I'm doing like maths all the time I'm running, in terms of what percentage of the distance have I run, and so maybe this isn't healthy behavior, but it's quite interesting having these insights myself, just, you know, and feeding them back into the research, I guess. More recently, and it's because I've observed differences in my sleep pattern because of lockdown, I suppose. So I didn't used to sleep an awful lot, so maybe 4 or 5 hours a night, with a long sleep once every fortnight. With lockdown, I noticed I was sleeping a lot more. I wasn't commuting anymore. But I also started, when I went back to the dentist, I was told that I'd been grinding my teeth. So I was kind of interested in thinking about my sleep a bit more, and as a sucker for technology, bought a stupidly expensive ring to monitor my sleep a bit better. And it's interesting because now I've got competing messages from Apple telling me that I'm great for smashing my exercise goals, but during March and doing all that running, my sleep efficiency has been okay, but my ring kept telling, the app that goes with my ring kept telling me to rest more and take rest days and so on. So it's interesting if you get competing advice from different technologies, and what do you then kind of go with, I suppose. The other thing that I've just kind of developed a bit of an interest in recently is biohacking. I suppose I had a 23andMe test a few years ago, and again, this kind of frustration of having the data and thinking about all the stuff that I'm tracking and how does it relate and what's the relationship, and not being able to do any real analysis myself. So I paid for some more, which is probably still not great. And if we think about, when we come to the discussion part, the kind of ethics questions and the ideas around, you know, what is this database? It's the information that it's drawing on is not population wide. It's people who have taken the test, which tend to be mostly white people, and obviously people who will pay 125 or 100 whatever it is for a test. So people who can afford it might be interested in that. So the pool is quite limited, and the way that they're doing the analysis and what they can actually tell you is, I know it's kind of foolish in some ways, but some interesting things came out of the additional analysis that I read a bit more in depth, and have started taking personalized 3D printed supplements this month on the basis of just experimenting a bit really with these ideas that perhaps I need to increase my intake of particular vitamins. The other thing that I find quite interesting, so this is actually from a screenshot from my test, but I am really clumsy. So the other thing that I record is falling over, which I tend to do more than probably the average healthy adult might do. I've always been really clumsy, but I tend to fall over a lot. In fact, I fell over last Thursday, which wasn't great. But you can see this one was detected by my Apple Watch, and the rest I've had to manually input. So I'm not sure quite how spectacular that fall was compared with the rest, but interesting that these ones I've had to input myself. But just thinking about something like Parkinson's disease, for example, I'm actually tracking things like this. It's not in my genetic information according to 23andMe, but who knows? But using, you know, tracking things like falls, but also looking at things like walking asymmetry, which my phone automatically does, and I look at quite a bit. You know, collecting this data again over the life course is perhaps quite a useful way of building up a picture of a person, and this might be useful information in the future. That I think, you know, if you then start to notice patterns, perhaps walking asymmetry becomes imbalanced, or, you know, you fall more regularly than that, maybe that's something that could be tracked. And I suppose, you know, older generations now where fall detectors, necklaces are being worn, or younger children or adult children, sorry, are perhaps trying to use devices, and things with older parents where perhaps the acceptability of technology is more of an issue, or the competence at using the technology is more of an issue, literacy and so on, digital literacy. Whereas, you know, thinking about myself and other people who might have been tracking over a longer period of time, actually building this picture and being comfortable with technology, in the future of sort of health and social care, we might see a bit more integration and use of some of this stuff. Again, it's not clinically verified, but it might help to paint a bit of a picture, and to pinpoint things that are potentially of clinical interest. So this is a technology that we're developing. So, and this is proving a bit controversial, but again, it's kind of into this idea of people perhaps wanting to track different aspects. And I'm working with an engineer to basically, I'm doing the kind of social science aspect of the work, looking at what might be acceptable, what kinds of features pregnant women might want. And the engineer I'm working with is going to develop the actual prototype technology, so we can have a look at that. So just thinking about sort of future uses and combinations of ideas of wearables, and actually building stuff ourselves. And the other one, this is actually a video, but I'm conscious of time because I've talked too much. I'll share it perhaps afterwards, but we built an ambulance drone, basically, myself and a student who's into hill walking, and she did a survey of what 5 items people might want within an ambulance drone that could reach someone up who's hill walking, mountain climbing, who could then use an app potentially to call this kind of ambulance drone and have the kit delivered to them. So it's not tracking, but this idea of, I suppose, building technologies as well. And she's a medical student who's just qualified, but she has actually been offered a job with a drone company to develop that idea a bit further. So we did make a prototype, which I'll share the link of that video, you can see. But it's this idea of, I suppose, just pushing boundaries a bit and actually taking that to the point of actually building some stuff ourselves as well. So I mentioned it a few times along the way, some of the kind of perhaps ethical issues, and that's something that I'm also interested in. And I was quite shocked to see this headline recently, 2 teenagers placed in foster care after weight loss plan fails. They were given Fitbits, you can see here, and were also signed up to Weight Watchers, but hadn't lost sufficient weight and followed the program. And were taken into care. I mean, that's what we can see from the headline, and I know from the way headlines look compared to what actually happens, or what I've actually said, it can be quite different. So I'm sure there were other issues going on, but obviously this idea of the Fitbit fitness tracker had been flagged, and so that's something that we obviously need to consider. And also published this piece for the World Health Organization on ethical barriers to artificial intelligence. So if we're going to start using data more, and using it, AI in particular, within the National Health Service, you know, that we might need to think about some of the issues there. And, you know, if potentially, if I were to like live stream all the data that I'm collecting on myself into my NHS health record, and if others were to do the same, how might that be used to make predictions or to make decisions around healthcare and healthcare provision? So just some things to kind of think about. And some other things here, you know, could these two worlds collide, and should they? Just thinking about, you know, the potential here for all of this stuff to kind of be joined up. but who's going to pay for it? How is it all going to be integrated? You know, how are the systems going to talk to each other, and which systems should talk to each other? Things around inclusivity as well. I mentioned age. Gender's come up quite a bit in terms of the focus of some of the projects here, but I suppose thinking about, you know, cost as well, and digital literacy as well, and training, and not just for people using devices, but also within healthcare services, you know, how, and then thinking back to the kind of early study that I did, the literature review, that was a real concern of clinicians about sort of data overload and how they would actually be able to use it. Ethics, we've touched on lots of questions there, and also sustainability in terms of, you know, if we keep building devices, and are we just creating a lot of sort of digital trash for the planet, and the production processes and so on, are they ethical, are they sustainable? I think is a real concern too. So I should stop talking now. I realise I've just run over time, but yeah, thank you very much for your attention, and happy to discuss, have questions.
We actually have a couple of questions. In particular, John has been very prolific in asking questions. I decided to hold off, and actually you touched upon quite a few of them in your last slide there. What we can start with is we'll start with a question from Peter. Will agreement on common data format for personal devices be difficult to achieve given the multitude of suppliers?
Yeah, I think that this is a real issue, and I know even for myself, I used a Microsoft Band a few years ago. Where I've used lots of different devices, but and Microsoft Band then took the Health Vault down, and you could download your data, but the data format when it's live is different from when you then download it as from the server, and I mean, I'm guessing that there are people who can write programs to get them to talk to each other and to be able to do these things. But there's one app that I use that actually is pretty good. It's made by the Quantified Self Movement, where you can cross-tabulate information from different apps that you might be using. So, for example, I could look at a particular vitamin intake in my excuse me, diet, and cross-tabulate that with my sleep patterns, for example, and it will do it on the app for me. So I suppose there are ways of doing that, but in terms of thinking about integrating into health and social care, I mean, every single NHS board, every department within that NHS board, and quite often different clinics will have programs that have been written for them at different points in time, and interoperability, I think, is the major issue. And certainly NHS Digital, there was a conference I went to maybe 3 years ago, and that interoperability was the kind of buzzword, but that seems to have disappeared from the main agenda. I'm not quite sure why, but yeah, it's certainly, and I don't think it helps either when in research, when we're kind of doing these research projects I was talking about, we keep building new platforms or new algorithms or use a new app, so it's just layering on more rather than using what's there. But obviously people want then tailored things, and what's there might not quite fit the purposes, and I think there are lots of issues there.
Do you see a role for data integrators or data aggregators in that kind of space then? So for example, Google Health does integrate with a lot of different softwares and different tools to then create a sort of unified platform.
Yeah, I think that would be really, useful. And obviously, I've mentioned a few times I use Apple devices. They seem to sort of interact really well, and with external apps as well. But I think if that's fine for people who want to pay for stuff, or you mentioned Google Health as well. So I think there are things that can be done, and it's getting better. And I suppose it will continue to evolve as well as we, who will know what kind of technology we'll have in 10 years' time. Will we have ingestibles, implantables rather than wearables, and what kinds of data formats? I don't know that we could get an agreement on a kind of universal data format. or what people's views of that are, but certainly it needs to be in a format that can be accessed or read in different ways, that's not just the kind of user interface but might interact with other platforms as well. But yeah, I mean, I'm not technical, and this is a lot of my frustration because of the amount of data, and I knowing what to do with it and how to read it and what sense to make of it. So I think there's a huge space there for developers and people who do have those skills to be able to shape that.
Excellent. In your previous answer, you kind of touched upon the cost aspect. So one of the questions from John was curious to know if the smartwatch study looked at access/ability to afford smartwatches. So this was the one with your undergrad student, I believe. Did the folks who did not have a wearable device indicate that they couldn't afford them?
We didn't actually find that in our population. It was more an active decision that they wouldn't. But what we did note in the discussion of that report was that there would have been a bias in the people who volunteered to participate, because if you don't have a smartwatch, you probably wouldn't volunteer to take part in a study on smartwatches, or it might sort of pass you by. You wouldn't necessarily express an interest unless you perhaps had a strong view. And we did note that the people who came forward who weren't having wearables had sort of actively made that decision not to use them, or had actively made a decision to stop using them. But it wasn't so much around cost. However, I was talking to a GP down south recently, who had said that patients were coming in and talking about using wearable devices, and that their sort of Avon catalogue versions of sort of £20 version of a Fitbit that people were using for weight loss and so on. So I think it depends on whether you are, I suppose, want an Apple Watch, or if you're an early adopter or someone who's interested in the sort of tech side of things, then maybe you'd want to look at the model and the spec and have the most sophisticated thing that you possibly could. Whereas for some people, maybe step counting's enough, and devices are getting cheaper. Although I was speaking to a colleague the other day, and he said that he has got a heart rate monitor on a device I think he paid £20 for. So it might be that there are some sort of cheaper devices, and certainly in some of the weight loss service in Aberdeen, a couple of years ago I did some work with them. They used a fairly low cost device that they did provide to their patients as part of their care, but cost was, they were looking for something around £50 within their budget. So I think cost is an issue, and certainly if devices were to be provided on the NHS, would you then be providing that that basic device to all people, or would it means testing and so on? I think that's a huge thing to consider. But I do think if you were to go to a GP, and you see now a lot of social prescriptions and other types of alternative prescriptions, and some of my previous work looked at financial incentives to participate in particular types of healthcare, which would have been more than £20 to actually pay somebody to do something in particular in relation to their health. And so I don't see why we couldn't have a model where it was available to GPs to be able to prescribe a wearable device that did some basic things. Or perhaps you might have a catalogue of different devices that, if you were concerned about a patient's heart and their weight, or their sedentary behaviour or something like that, that you could, like that table with the heart health, you could almost have, what things do you want to monitor, and then which devices do what, and be able to prescribe those, or something like that. That could be something that we would look at in the future. But the other thing with that is that would have to be kept updated as technology progresses, and so on. So I think there are lots of issues with that as well.
Yeah, so quite interestingly, it links into the next question. Have there been studies looking at the benefits of digital health technologies over short versus long periods of time, given that digital health technologies are constantly being updated and improved?
Yeah, so actually a lot of the studies and our own have shown, well, it depends on what you're monitoring. So if you're monitoring something, a particular, like your heart, for example, let's use it as an example, then it can be good over a short, it seems that it can be better over a shorter period of time, so that you're not actually getting sort of user fatigue, or people kind of getting obsessed with their data or depressed with the data. So actually using it for a sort of short-term goal, or short period of time for a particular function can be quite useful. What I haven't really talked about too much, because it's not my area really, but a few conferences I've been to, early conferences, the apps that showed most promise were mental health apps, mindfulness apps, that kind of thing. And I think they seem to be working over a longer period of time. So not for diagnosis or not for that kind of initial monitoring, but actually sort of long-term management. So I think, again, that's different. And obviously, if you're like, some of the studies that we've worked on fertility tracking, you kind of need it to be over a period of time, a longer period of time, perhaps. So I think it really depends on that kind of combination of factors, and whether it's, healthy. I'm someone who's been tracking a lot of things over a long time, and I still think I see benefits in doing that. But obviously I reflected on, maybe I'm a bit obsessed, or maybe I'm a bit strange, I don't know. But I think
there was certainly an amount of data recording that you go through.
Yeah, absolutely. And I can't see a time that I would stop doing that. I mean, maybe it would happen, but in the general population, I think it would really be in conjunction with, medical advice, or working out. And I suppose that comes to sort of personalized medicine and patient-centered care, and patient involvement in the shared decision making, which are all sort of underpin what our NHS is about. And so really, I suppose it would be with individuals not just looking at the parameters that they should be tracking, but actually what that tracking journey might look like. And that's obviously if it's kind of that proactive reactive tracking because of a particular thing happening, versus that proactive tracking over a lifetime, for example.
Mm-hmm. I actually reached the end of John's questions. Is there a correlation between health literacy and the use of digital health technologies?
Yeah, and I think this is a major issue, and it's not just cost, accessibility of being able to get devices that is a major issue for inclusivity, but also, certainly digital literacy, and not just, I think I touched on this earlier on, not just among patients and people, but also among clinicians, and that kind of panic of using it, thinking about it as meaningful when it might not be, concern there. The interviews that we did with doctors and nurses, really kind of, if they're not familiar with the device or the type of the format of the data, or whether it's accurate, or those kinds of things can be an issue, and then integrating that into kind of healthcare. But also, if people are not data literate, and quite exactly what that means, because I've kind of reflected myself, I can see the numbers of my own stuff, but I can't really do anything very sophisticated with it myself, because I don't have the skills. So there's always a limit, and your expectations there too around, well, who is digitally literate to be able to do something with that. So, like, for example, I send some of my data to a computing scientist, a friend of mine. I've also sent genetic data to someone I know who knows how to do stuff with genetics. So it's that kind of, I suppose, what do we mean by literacy? And I've also seen a project that happened in a local school, and it was with adolescents who had been described by the school as disaffected, and they'd been given devices to where they'd been given them initially in school to wear during school, and then they had been allowed to take them home. And the idea that they were getting these kids to wear them to think about their sleep. So there were perhaps kids who weren't doing their homework, were staying up all night, they weren't participating in physical education at school, they weren't that concerned about their health, but they were kind of sectioned off and then given all these challenges and monitored using the devices and so on. And I just kind of wonder, and I suppose this isn't just about literacy, but that kind of experimentation is a tricky ethical one. But in terms of the kids' engagement, the report that was written on that, it seemed that they were more positively engaged with school, with physical education, they were sleeping better, eating better, and so on. It was a small number, but what did those kids make of that data and how it was being used and such is an interesting one as well. But yeah, there's quite a lot of health trackers for children, and you do think if parents sort of track their kids sort of from a really young age, and then maybe that kind of literacy might be built into the sort of parenting relationship. I don't know. Again, the appropriateness of that and the ethics is an interesting one. I suppose it's like when, I think is in France, that there's a law again, that kids can sue their parents basically if they put pictures of them on Facebook since they were a kid, and once they get to 18 they can complain. Is this kind of tracking, if schools are doing it, if parents are doing it, will there, and if it becomes part of healthcare, will literacy kind of come with it, or is there something that we need to do around that? I think, yeah, it's multi-layered.
Cool. Stepping away a little bit from the kind of personal health devices and things like that, got another question. Have you tried integrating health-related data from different sources? People get very uptight about privacy and try to stop you, but in a pandemic, it can be counterproductive. For example, German COVID vaccination got held up because the hospitals couldn't even get a list of patients which were over 80. And the question continues, is most of the data that you can get anonymized, so you can't actually link it to other data about the same person?
Yeah, I think that is, and I work or am co-director in the Aberdeen Centre for Health Data Science, and my colleagues who are health data scientists who work on big data linkage studies always emphasize the fact that the data are anonymized as a kind of security, as a reassurance to people that, if your data is being used in research, we don't know who you are. We're not looking at your personal health record, that they are not looking at an individual's, they're not going to be able to identify you from the information. It's all anonymized, so that links between different types of data can be used for research purposes to answer sort of bigger questions. But then that kind of backfires if that information, not for research, but certainly in healthcare, if data are not linked. In fact, I received an email earlier on today from a medical student in London who wants to work on a project that looks at rare conditions, because she was saying that there are some digital technologies that are available that could I suppose integrate or minimize the amounts of contact that people might have to have with different health services, because they're having sort of duplicate appointments with different, so they might have multiple aspects to the rare condition, that they might go to this clinic for that, go to the GP for that, have that consultant for this, have that, but actually there's actually a lot of overlap with what some of these people will be doing. So they're probably undergoing multiple of the same tests where they only really need one, because if that consultant could access the information from the previous consultant, but none of the systems talking to each other, but for the patient themselves, it would make such a difference if that whole package was a package, that they were seen as a person, not sort of transacting with all these different divisions and having data collected about them and then kept in a record, in different places. So I think, you know, and I wonder if we would see in the future actually a patient having control of that kind of health kit. So at the moment, we go to a doctor and, you know, you might be given some information, but it's mostly kept within the health service. We don't really know, you know, what is kept about us unless we request it. But maybe if patients became in charge of their own sort of data and data sharing, then it would be possible then to, you know, go and see a doctor and the doctor say, well, I would like to see this, this and this. And then you give them sort of a digital approval to be able to access that, the things that they need. So it's kind of need to know basis. And at each time, perhaps that's a model that might work in the future.
So it's quite interesting. So I'm originally Swedish, and in Sweden, the certainly in the west of Sweden where my parents still reside, the digital health tracking system that they have is that all providers of healthcare link into one system, and they have to upload tests to it. So if you have a blood sample, if you have a blood test, the results are delivered to you on that platform. But it also means that any other digital health provider or any health provider would be able to access your blood test, because if you had a cholesterol test and your cardiac doctor would like to do a cholesterol test, well, actually, it doesn't need to because it already has the results. So it's quite interesting. Do you think that there's an appetite in the UK? Obviously, I think there's a lot of privacy concerns around allowing that kind of government shouldn't have access to my data. Do you think that's something that is changing, like in public opinion?
I'm not sure that it's changing, and I certainly think there would be a lot of concern in the UK context around, you know, what does this mean in terms of the NHS and privatisation if, for example, you know, that some of these ideals or ideas were put into place because they might involve third-party data collection methods. You know, a lot of the stuff that I've done at home myself is through commercial and, you know, home-based stuff. I don't know that there's a huge, I think people would be really concerned if it looked like it was going towards that model, like you could go to the GP and they would prescribe you a Fitbit or something like that and then expect you to share the data, that it would feel a bit more like a sort of, not privatized, but it would have a different feel compared with the NHS that we're used to, and which in the UK is highly valued, and people like that kind of model, and panic when, you know, that the kinds of reviews that are done, probably most of it in the current government administration that have been done around sort of digital health and ideas, I think that probably there's not an appetite for it, and I'm not sure how well received these kind of ideas would be, and sort of ideas around surveillance, which goes back to that kind of policing thing that I was talking about earlier on. I think people would be really concerned about that, but also even in terms of, I suppose, popular culture and literature, thinking about sort of 1984, the George Orwell stuff, and that creeping in, but also there's I can't remember the name of the author. It was a film, The Circle, but also a book. Is it Eggers? I can't remember the name, but really interesting, this idea of actually your work, your social life, your bank balance, your health status, and everything being interlinked, and having all these kind of targets that I know it's sort of a bit futuristic, and it really emphasizes the potential negatives, but I think people maybe perhaps a bit concerned about that. But then saying that, people use Facebook and, you know, sign into things using Facebook, and they have a Tesco club card and so on, and these kind of organizations have a lot more information about us. So I suppose it's about the benefit, because, you know, if I use a Tesco club card, I get vouchers that are tailored for me. If I use Facebook, I get to keep in touch with my friends, and it's easier if I don't have to keep creating passwords to sign into this, that and the other, when I can just go through that. So if there's a benefit, an immediate benefit to me, then that's maybe the kind of sell. And I just don't know that the benefit is clear of some of these health type technologies yet. Is immediate enough, or if people are generally are that engaged in health or want to be reminded of it all the time. And that's the other thing, people with conditions, you know, if you're asking people to constantly track or do things, do you want to be constantly having this identity of being someone with a condition or of being ill or sick? Do you want to live as normal a life as possible without being constantly, you know, buzzed for, can you input this information, can you share? So I think it's really, yeah, complex. That doesn't really give you an answer, but yeah.
I'm going to take the last couple of questions. Peter asks, suppose you find during a trial of anything that a person has high blood pressure but doesn't actually know about it, you know, should you tell them in that kind of circumstance?
Yeah, that's protocolized. So you normally have to think that through. If you're collecting that information and using it, then that would be in a protocol that you would then have, and you would have to make that clear to patients as well, whether you're going to do that or not do that, or sorry, participants. So if you were going to be able to see something in particular, then you would already have alerted the patient that either we will tell you if we notice this, or we won't tell you if we notice that. But then that's an ethical question. And obviously with designing any study, if you're deciding to tell people or not to tell people, then you have to clearly state, you know, why that is and how that's going to be done. It also might not be, you know, as researchers, you might not be the appropriate person to communicate health information to a person. So it's that's usually decided with the research team and the ethics committee, what the arrangement there is on a study by study basis. But I think actually that will become even more, I suppose, as different technologies. So at the moment, a lot of the technologies are kind of bespoke that are used in trials, or they can only do one thing at a time, and we're using multiple things to join up the things that we want to do for that particular trial. But in the future, you know, if you were to use Apple Watches, for example, then that might be able to detect things automatically. I mean, for goodness, my Apple Watch, every time I leave the house and come back now, it reminds me within 20 seconds I need to wash my hands. So, you know, there are so many things it knows that I'm home. So there's so many functions and things. And at the moment, I think we're still using quite limited devices, limited technologies, but that will become more of an issue in the future.
Cool, excellent. Why not concentrate on making integrated data available to the patient, as you suggest, but exclude kind of big pharma or Facebook or any of those?
Yeah, I suppose that would involve quite, well, in the UK context, quite a drastic overhaul of the NHS if the NHS were to lead it, rather than all these external commercial interests. I think there's just probably not enough money to invest in that. You know, could a new system be created that is the NHS brand, that replaces all of their computer systems and technologies and kind of is built from the bottom up, or it's kind of restarted? How would that work? I suppose that would be the ideal, because you could then have this sort of trust in it that it is about the health service. It is about health, not about data and money. But how possible that is, I don't know. It would be really cool, but I don't know which health secretary might, for the UK anyway, it might commission that kind of approach, but you never know.
You never know. I'll take the penultimate question. I'm going to finish up with my own question at the end. Do you think that smartwatches could be used massively in the future in order to fight non-communicable diseases?
I think so, but I do think so. Some of the other work that we did within the wearable device for weight loss among women, we coded all of the different behavior change techniques that were contained. So there is a list of 93 behavior change techniques that have been created by health psychologists and are used to code different interventions and so on. And I find it really interesting when we do that with digital health technologies, because there's actually quite a lot that is built in that can be tailored for different types of people. So someone like me, I love the tech, I love the tracking, so I'm kind of idiot for it because I do it. But for somebody else that might not work. So for me, I know that how much exercise I'm doing, that I'm meeting the guidelines, that I'm meeting the dietary guidelines, so I'm following all this stuff and I've got the evidence to show it. But I'm engaged. So how do you engage people who aren't engaged in it to help with the kind of lifestyle aspects and management and so on? And I think that's always going to be, like with any sort of campaign or any approach or intervention, it's a hard sell. And I think we need to do more research around what digital tools might appeal or might work for people that's not, I think work with populations rather than, and we used to call it hard to reach or harder to reach people, but I think it is, there's no good, like in all research, asking the engaged is, what about the people who aren't engaged? And I think that work needs to be done to establish what potential value smartwatches could have.
Excellent. I want to go back to kind of early in your talk on the different medical trials. So you had the kind of almost customer satisfaction between the skin and the asthma trials, where in the skin trial people seemed more happy with the conclusions because it was a person making decisions, people were reviewing it, whereas in the asthma one it appeared to be more there's an algorithm, it's cold, it's not as fuzzy wuzzy. My question there kind of becomes, do you think that the doctor bot of the future is going to have a big struggle as a result of actually makes fewer mistakes than human doctor, but isn't a human?
Yeah, I think, and that project, the asthma one, was really interesting in that regard because, we actually specifically asked, how did you explain the algorithm to patients? What language did you use to explain the algorithm? Like talk us through how you explain this. But actually, it seemed less that the participants were concerned about the algorithm, because they talked about the safety net. And knowing that a doctor wouldn't do, so even if they were following the algorithm, they wouldn't do something that was harmful. And they quite liked the idea that it was tech-based and that it was personalized data-based. It wasn't, it was live because it was based on today's data output, exhaled nitric oxide, that it felt, the maths, it was very clever because the algorithm was developed by clever people to do clever things. So there was this positivity there, but it was really the clinicians, where the clinicians were saying, actually, there are aspects of the algorithm that we don't like because it's not taking into account the weather or the season, or the fact that that child's smart inhaler, the cutoff for morning and taking their inhaler was noon, and actually some of the teenagers were laying in bed till the afternoon, so they might have taken their inhaler but at 12:30 in the afternoon as the morning. So I think it's that kind of need to be able to refine what's going on within some of these computer programs, and I suppose that's going to happen over time, and we will obviously, that was developed for that particular study, but taking that forward, we've learned from that, and that's not going to become part of clinical practice yet. There'll be some more research. In fact, there's some researchers in Oxford who are doing a bit more work on that, and who I met with recently, and was sharing some insights around what we'd heard around the algorithm. So I think there are some exciting things, but I think, and the algorithms have the potential to be better than the doctors, but I do think with artificial intelligence and so on, that we need to make sure that the data that these algorithms are based on, and the information that they take into account, are better, more sophisticated, before we completely let them get on with it. But I think they will be really useful. But what we seem to be hearing at the moment is they'll be really useful, but if combined with an actual person as well. And I don't know that we'll ever go fully digital in that sense, that I think we'll always want that kind of, well, maybe as this year's told us as well, we can go fully digital when we have to work from home or whatever, but actually the need for human contact is quite important and strong. So yeah.
I think that's a great note to end this on, actually. Thank you very much. It's been an absolute pleasure to have you present for us tonight. The talk has been recorded. It will be made available on the BCS YouTube. We will also put it onto the BCS Aberdeen website. Will the slides be available kind of as a separate? I'm sure we can arrange for that.
Yeah, I'll try and resend you the slides. I'll send them to you in a format that you can actually access. But yeah, no, I'm happy to make all and any of it available. And yeah, thanks so much for questions and participation and so on. It's been great. Thank you.
Thank you very much. And on that note, I will click end and see what happens.
Perfect. Thanks, everyone. Thank you.
Thank you. Bye.
Bye-bye.